thank you very much for joining us for the bite-sized videos. This time we have somebody from the obstetrics and gynecology department doing some great presentation on deceptive symptoms, conditions mistaken for UTIs in women. I'd like to introduce Dr. Sarah Evans to you. Sarah, welcome to this presentation.
Thank you for having me.
Very good. Sarah, before we go into nitty-gritty, I've always wanted to be an OB-GYN, but I didn't have a good reason. Tell me, what made you go into the OB-GYN world?
I think I've always cared a lot about women's health, and then I fell in love with the surgical part of it during medical school. So, combination of the two things.
Excellent. Yeah, surgery is probably not my strong suit. I think that's why I stuck to the medicine. So you will be talking to us about deceptive symptoms, conditions mistaken for UTIs in women. I think it's an extremely important topic, especially knowing that lots of antibiotics are prescribed for conditions that may not necessarily be a urinary tract infection. So we really appreciate that you are getting into the nitty-gritty of this.
Well, thank you very much for having me. So I've been tasked with discussing some conditions that are often mistaken for urinary tract infections in women, or when symptoms are deceptive. So first of all, this is a really common problem. 11% of women report UTI symptoms each year. There's 9 million office visits for women with UTI symptoms annually. And this is old data, but at least $3.5 billion are spent in our country each year for evaluation and treatment of UTI symptoms in women. So what are these symptoms? So dysuria, urinary frequency, urinary urgency, hematuria, and suprapubic tenderness. Fever is uncommon in women with uncomplicated acute cystitis. And women who present with one or more of these symptoms have a pretest probability of 50% of having urinary tract infection. So let's talk about risk factors first. So when should we be thinking about UTI? So women in general are more predisposed to urinary tract infections due to the short female urethra, 2 to 3 centimeters long, and the short distance between the urethra and the anus, especially in sexually active women. Women who use spermicides have a history of UTI, known stone disease, diabetes, catheterization, known genitourinary congenital abnormalities, poor hygiene. Menopause in and of itself can predispose to urinary tract infections, as well as incomplete bladder emptying and pelvic organ prolapse. So for women who come to the office complaining of a UTI, if they have both urinary frequency and dysuria, their pretest probability of truly having cystitis is 73%, whereas women who present saying they have a urinary tract infection but do not have urinary frequency nor dysuria have a pretest probability of only 23% of truly having cystitis. And of those women who have both urinary frequency and dysuria, if they also deny any vaginal discharge, their pretest probability is 90% of having true cystitis, whereas those who also have vaginal discharge, that will significantly reduce their pretest probability of having a UTI. And of course, to make the diagnosis of urinary tract infection, you need to do a urinalysis or urine testing. And if both nitrites and Luc esterase are positive on a urine dipstick, sensitivity of a urinary tract infection is 75% and specificity is 82%. The urine culture, of course, will then confirm bacteriuria, gives antimicrobial susceptibilities, and our traditional cutoff for a quote positive urine culture is at least 100,000 colony-forming units per milliliter of bacteria. And while this has a very high specificity, the sensitivity is only 50%. So that is, of course, something to keep in mind in women who keep presenting with these recurrent symptoms or who are truly very symptomatic that perhaps we should be considering lower thresholds to treat. The American Urologic Association does have guidelines on how to evaluate women who present with recurrent UTI symptoms. Those guidelines include obtaining a complete history and performing a pelvic exam in women presenting with recurrent UTIs. To make the diagnosis of recurrent UTI, a clinician must document positive urine cultures associated with prior symptomatic episodes. Consider obtaining a repeat urine study if that initial specimen is suspect for contamination. Cystoscopy and upper tract imaging is not routinely obtained in index patients. And clinicians should obtain urinalysis, urine culture, and sensitivities with each symptomatic acute cystitis episode prior to initiating treatment. There is a role for patient-initiated treatment in very select recurrent UTI patients with acute episodes while awaiting urine cultures, but of course this is once we've already established the diagnosis of true recurrent cystitis. So then, what about when the urine cultures are negative and women keep presenting with these symptoms, but there's an absence of bacteriuria? So one of the most common things I see is the genitourinary syndrome of menopause, which we'll talk about in a second. Vaginitis includes yeast, bacterial vaginosis, trichomoniasis, urethritis. Overactive bladder is a syndrome defined by a group of lower urinary tract symptoms, including urinary urgency, urinary frequency, nocturia, and urgency incontinence. And there's a variety of treatment options available to women with overactive bladder. Neurogenic bladder is a similar spectrum of symptoms, but when they are attributable to a known neurologic diagnosis, like poorly controlled diabetes, multiple sclerosis, etc. Interstitial cystitis or bladder pain syndrome is chronic pain, pressure, discomfort, some unpleasant sensation localized to the urinary bladder with associated lower urinary tract symptoms like urgency and frequency. In the absence of a bacterial infection or other obvious identifiable cause. And there is, of course, a treatment algorithm available to women with interstitial cystitis. Nephrolithiasis or stone disease. There are different vulvar dermatopathies which can present as dysuria, including lichen sclerosis, lichen planus. I've even seen extramammary vulvar Paget's disease present with dysuria. These things can be diagnosed with a pelvic exam. Genital herpes, urethral diverticula will present with dysuria, urgency, frequency, dyspareunia, and urethral mass on exam. And then trying to think out of the box even more things, chronic pelvic pain due to things like levator or urethral syndrome or primary pain diagnoses can sometimes be mistaken as urinary tract infections. And then other things that can cause pain or discomfort in the pelvis, like irritable bowel syndrome or pelvic inflammatory disease. So then specifically, genitourinary syndrome of menopause or GSM is very common in postmenopausal women and can really significantly impair their health, sexual function, and quality of life. Symptoms include vaginal dryness, dyspareunia, vulvovaginal burning or irritation, but related to the bladder, dysuria, urinary urgency, frequency, and even truly frequent cystitis episodes. It's often underdiagnosed and therefore undertreated, and it can be treated using over-the-counter non-hormonal vaginal lubricants and moisturizers or prescription vaginal estrogen creams, tablets, or inserts. So how to evaluate the patient presenting with quote, UTI. So taking a good history, performing a pelvic exam, obviously testing the urine with the urinalysis or urine culture as indicated, considering doing an affirmed vaginitis panel probe, monitoring chlamydia testing, and then imaging as indicated. So for example, if she has gross hematuria and you're worried about stones, then a CTU. And when to refer to a urogynecologist in particular, a woman with persistent, recurrent, or refractory lower urinary tract symptoms. Once you've established the diagnosis of recurrent UTI to help her prevent future UTIs, a known genitourinary anatomic abnormality or history of prior surgery. So these are all just some suggestions of when to refer.
Dr. Evans, thank you so much for your great presentation. I really wish I could have been an OB-GYN, but I guess in
your next life.
In my next life, I'll try and do that. So for the primary care provider, when do they have to refer a patient or think about referring a patient to a urogynecologist because the patient may have symptoms that could suggest that they have UTI, but probably they do not have a UTI?
Yeah, good question. I think that's any woman with persistent, recurrent, refractory, irritating, bothersome, lower urinary tract symptoms, or, truly have already met the diagnosis of frequent or recurrent urinary tract infections. Anyone who you suspect some kind of anatomic abnormality, like a urethral diverticulum, for example, or someone who's had surgery, genitourinary surgery, has had, a bladder tack at some point, or even, whatever it is. Those are some kind of bare minimum. But I think the most important is just the persistence of these symptoms. If they're bothersome and the urine cultures keep coming back negative, then that's a great time to refer to us.
Okay, excellent. Once again, thank you so much for doing these bite-sized videos. We know it will go a long way in improving our antimicrobial stewardship and guide our providers in making the appropriate referrals or thinking about these conditions to make the appropriate referrals when needed. Thank you so much.
Thank you.